It's a real pleasure to introduce Dr. Atul Malhotra, one of the leading voices in sleep medicine and a true pioneer in our understanding of sleep apnea. Dr. Malhotra serves as Vice Chair of Medicine for Research at the University of California, San Diego, and has made foundational contributions to the field of pulmonary critical care in sleep medicine, helping bridge physiology with real-world clinical care in a way that has advanced the field for all of us. Beyond his impressive work of research, he is widely respected as a thoughtful clinician, an innovative researcher, and a generous collaborator. We're genuinely fortunate to have him here today to share his insight on modern strategies for managing sleep apnea. Please join me in giving him a warm welcome to Dr. Malhotra.
Well, thanks very much. Thank you for that introduction. My name is Atul Malhotra. I'm a pulmonary critical care physician at UC San Diego. I'm going to be talking today about modern strategies for managing sleep apnea. It's my pleasure to be here. It's quite an honor to share the podium with such distinguished speakers. There are some disclosures here which may be relevant. In particular, Eli Lilly funded the SURMOUNT OSA study, which I'll be discussing. By way of background, we've estimated about 1 billion people worldwide with obstructive sleep apnea. We had data from 17 of the 197 countries, and so the other results were extrapolated from existing data on gender and body weight and race from other countries. So that number 1 billion is an estimate, and since that time in 2019, the numbers have increased, not decreased, as a result of the obesity pandemic and the aging of the population. Now, some people say, who cares? Why does it matter if there are people out there with sleep apnea? Unless they come to clinical fruition, maybe let's just leave them alone. So we published this paper just over 10 years ago now. Raphael Heinzer trained in my lab, and he's now very successful in Lausanne, Switzerland. And we went into the community in Switzerland and did polysomnography, full sleep studies in the homes of people in Switzerland. And in that context, we measured moderate to severe sleep apnea based on apnea-hypopnea index over 15 events per hour in 23% of women and 50% of men. So that means people stop breathing once every 4 minutes or more. There's really no debate that those people need treatment. For breathing index over 5, we could debate it. Over 15, there's not a lot of debate. And 23% of women, 50% of men had evidence of clinically important obstructive sleep apnea. I'll point out there's a lot less obesity in Switzerland than there is in the United States, so they're catching up. But again, people said, who cares? If they have disease and they're not coming to clinical fruition, leave them alone. Well, we did a multivariate analysis in that context, and the apnea-hypopnea index, the marker of sleep apnea severity, was predictive of hypertension, diabetes mellitus, and depression. So it's hard to say let's ignore these people when we know they're afflicted with important conditions. I'm not saying sleep apnea is necessarily causing all these conditions, but it's hard to say let's ignore people when we know they're suffering. It does lead to a concept, though, that sleep apnea is highly prevalent, but not all these patients will get cardiovascular benefit from CPAP, continuous positive airway pressure. Why would I say that? It would surprise me if 50% of men in Switzerland had cardiovascular benefit from CPAP, because not all are at cardiovascular risk from sleep apnea. Some will die of Alzheimer's, some will die of heart disease, some will die of heart disease for other reasons than sleep apnea. Some will die of cancer and other things. And so it would surprise me if this one-size-fits-all approach of just giving half of the men in Switzerland CPAP is not going to work. More recently, we've projected future burden of sleep apnea. And so this was published in Lancet Respiratory Medicine a few months ago, projecting the 30-year burden of sleep apnea. And this is with colleagues for the MedX Cloud. It's an academic industry partnership. We saw that sleep apnea prevalence is increasing, particularly in women. GLP-1 receptor agonists, these weight loss drugs we'll talk more about, have some effect, but no major effect at a population level. Sleep apnea will increase to about 35% to 77 million cases in the United States. And females will increase about 65%, while males about 19%. That difference related to obesity and aging trends currently. So take-home message so far is that sleep apnea affects up to 1 billion people worldwide. The numbers vary with the scoring criteria and the equipment used, but we need to think about how to address this global burden of disease. So I'm showing you this slide for a couple of reasons. This is my most famous patient. This is Shaquille O'Neal, who's now doing advertisements for tirzepatide for Eli Lilly. But he was my patient when he was diagnosed with moderate sleep apnea. He was playing for the Celtics. I'm showing you this for a couple of reasons. Number one is it's cool. Number two is he's not the stereotype of sleep apnea. He looks quite heavy on TV, but at the time he was playing for the Celtics, he was 340 pounds, but very cut in terms of his muscles and very good shape. But despite that, he had moderate sleep apnea. So that stereotype of older obese men having sleep apnea is simply a stereotype of plenty of skinny women and others who come to my clinic who have sleep apnea and don't fit the stereotype. And so the other reason I'm showing you this is my wife says he makes me look thin. So many of you are familiar with this study. This is the SAVE study published in New England Journal of Medicine 10 years ago now. CPAP for the prevention of cardiovascular events in patients with obstructive sleep apnea. And this was done in Australia and India and China and Brazil and other countries. Therapy of CPAP plus usual care, as compared with usual care alone, did not prevent cardiovascular events in patients with moderate to severe sleep apnea. So this was disappointing to many people who were hoping giving CPAP, continuous positive airway pressure, would treat sleep apnea and prevent heart disease, but that was not shown in this and other randomized trials. And so there are at least 3 or 4 conclusions we could draw from that. Number one is we need better therapies and better adherence. The authors tried to achieve 3 hours per night of CPAP use, which is what they did achieve. But maybe that's not good enough. Maybe you need more CPAP use to really get the full benefits. We need to identify high-risk patients better. Again, this idea that 50% of men in Switzerland will get a cardiovascular benefit from CPAP seems unlikely. We need more basic research regarding mechanisms, which is a shameless plug for my lab. And then we need to treat the underlying cause, which in many cases was obesity, which was largely ignored in the past. So therapeutic approaches to sleep apnea use CPAP, continuous positive airway pressure, to hold the airway open. CPAP has a fairly bad reputation. Some people say nobody tolerates it, and I'll show you data suggesting that's simply not true. So these are data we published from the MedX Cloud, this academic industry partnership. It's a partnership with ResMed. I'll point out I don't take money from MedX Cloud or from ResMed. But on the cloud, there's over 23 billion nights of data available on the cloud now. It's quite a rich data source. And so what we did there is took 137 million nights of data and found 1 million patients and did propensity matching. The blue people are getting usual care, and the red are getting active patient engagement with modern technology. So on the x-axis here is time. On the y-axis here is the cumulative percent of patients. If you look at usual care, about 70% of patients meet U.S. Medicare criteria for CPAP adherence. That's pretty good, 70%. It's not bad. If you look at active patient engagement, where they get a thumbs up if they're doing well, helpful hints if they're doing poorly, about 87% of patients meet U.S. Medicare criteria for adherence. And these two groups are propensity matched. It's not a randomized trial, but suffice it to say CPAP adherence is quite good. And this idea that nobody tolerates CPAP is simply not true. Now some people say, well, this is biased because you're only showing people that got a CPAP machine. That's true. So we tried to be as inclusive as possible. If you got a CPAP machine and were able to plug it in and use it for 1 hour in total, then we included you on this slide. If you had no access to health care, or you refused a sleep test, or absolutely refused to ever get a CPAP machine, you'd never show up in the slide. But these data do pertain to the vast majority of patients that we see in San Diego or in Los Angeles. So if that sample size wasn't enough, we looked at 2.6 million patients and again saw about 75% adherence based on U.S. Medicare criteria. We looked in under-resourced areas as well. So we had 4.1 million patients in the United States, 31,000 from Brazil, and 16,000 from Mexico. And in that context, we're seeing about 74% adherence based on U.S. Medicare criteria in the United States, about 72% from Brazil, and about 66% from Mexico. Now, people say these are different patients, and that's exactly the point. We were trying to compare results across different healthcare systems. You might argue that people coming to clinical fruition are more affluent than the average Mexican, and that's probably true, same in Brazil. But suffice it to say there was acceptable adherence across the board here in these 3 different geographic areas. These patient engagement tools that I mentioned, the helpful hints if they're doing poorly, thumbs up if they're doing well, they were built into the machines here. They're associated with a 2x benefit, but they're grossly underutilized. And so there's something actionable here where you can just turn that on as a feature in the equipment and patients with active patient engagement get better adherence with existing technology. And it turned out about 80% of patients meeting Medicare criteria were still using it at 1 year, suggesting sustained benefits. So we published a bunch of different studies with MedX Cloud, some in heart failure preserved ejection fraction, some in reduced ejection fraction, in diabetes, in AFib, healthcare resource utilization, and in COPD as well. I won't go through all these different studies, but suffice to say there's a lot of activity that treating sleep apnea might improve outcomes in various different cardiometabolic diseases. So this was a bit controversial, but we published this about a year ago in the Lancet Respiratory as well. This is a meta-analysis of all the randomized studies and non-randomized studies regarding CPAP. Randomized controlled trials are above. Non-randomized controlled studies are below. On the left is cardiovascular mortality, on the right is all-cause mortality. Again, randomized trials above, non-randomized studies below. If you look in aggregate, the randomized studies don't reach statistical significance for all-cause mortality or for cardiovascular mortality. But in aggregate, these studies are quite small. There's a total of about 4,000 or 5,000 patients in them. They tend to enroll fairly asymptomatic patients or minimally symptomatic patients with short durations of follow-up, and so their event rates are quite low. If you include non-randomized studies, you get over 1 million patients, as opposed to a few thousand with randomized studies. And if you include all those, you do get statistical significance for all-cause mortality and cardiovascular mortality over here. Now, the non-randomized studies are susceptible to bias. There's a healthy user effect where the people using their CPAP are perhaps more educated or better socioeconomic status than those not using CPAP. In addition, there's residual confounding, so if you don't randomize, there may be factors that we're not aware of, unknown covariates, that may be explaining some of the results here. So suffice to say that these results are suggestive but not definitive. Ideally, we'd have much larger randomized studies with tens of thousands of patients rather than a total of a few thousand. But the data are interesting enough that CPAP is at least associated with improved cardiovascular mortality and all-cause mortality, and perhaps we need future randomized trials to prove that definitively. So nasal CPAP is first-line treatment for obstructive sleep apnea. It improves symptoms, it improves blood pressure, has transformative benefits for some patients, and a defeatist attitude about CPAP saying nobody tolerates it is simply not justifiable based on the data. But there's general acknowledgement which we need new therapies based on ongoing research, which is the focus of the remainder of my talk. Let's talk about upper airway surgery. You've seen the ads on television for Inspire. It's a hypoglossal nerve stimulator. It sits on the clavicle and it electrically stimulates the tongue, pushes it forward, and the TV ads make it look like it's just a remote control. It's obviously more involved with that. We've been working in that space as well. There's different types of nerve stimulators. We've been looking at what's called targeted, or it's now called proximal, hypoglossal nerve stimulation. This is funded by LivaNova, which is a company in that space, and as I mentioned, I consult for LivaNova. This is published in JAMA ENT, where we did what was called the THN3 study. On the y-axis here is the median number of events. Here's the oxygen desaturation index. At baseline, 4 months, you can see with active treatment there's a marked decline in the apnea-hypopnea index on the left and the oxygen desaturation index on the right, and sustained benefits out to 12 to 15 months, suggesting that this is a decent treatment based on this THN3 result. But we didn't feel it was compelling enough, and so we did another study, which is not yet published, but I presented it at the American Thoracic Society meeting last year, so I'm allowed to share it now. It's called the Osprey study. This is proximal hypoglossal nerve stimulation, which improves sleep disorder breathing and sleep apnea. So this is on the proximal hypoglossal nerve. It's a simple procedure that can be done quite quickly by an ENT surgeon, and I was honored to be the global principal investigator for this study. The design of that study was published in Contemporary Clinical Trials. There have been some press releases out already showing that there was improvement in this so-called Osprey study. The primary endpoint here is the apnea-hypopnea index response rate based on the so-called Sher criteria. AHI response rate on the y-axis here. We did a sham controlled study, so everybody got implanted, and then a third of the patients had the machine left off, 2/3 had it turned on. And so we had a control group there. The prior study, the Inspire device you see on television, was published in New England Journal back in 2014, but was not a randomized study. It was an observational pre-post kind of design. So here we have level 1 evidence, randomized evidence that active treatment has a much better response rate than the controls, and I'll show you that this does improve over time as well. If you look at the Epworth Sleepiness Score as a marker of sleepiness, daytime sleepiness, that improves markedly with active treatment compared to controls. If you look at the Functional Outcome of Sleep Questionnaire, which is a validated metric of sleep apnea improvement, that does improve with treatment more so than with controls. And this press release showed the long-term outcomes at 13 months. After the first 6 months, the control group that had the machine not turned on, or the stimulator not turned on, did have it turned on after 6 months. And so we had long-term follow-up in everybody in active treatment. We got a response rate up to 65% now. The median apnea hypopnea index goes from 34 to 11. The median oxygen desaturation index also gets down to 11. And so it looks fairly compelling that this active nerve stimulation with the proximal hypoglossal nerve device is showing benefits. So I'll conclude that portion of the talk saying the proximal hypoglossal nerve stimulation provides safe and effective treatment for sleep disordered breathing, oxygenation, and quality of life in an obstructive sleep apnea cohort that closely resembles the target clinical population. The prior study in New England Journal was 97% white, predominantly male, and so really not very generalizable. We did take measures to ensure some good diversity in terms of our participants in this Osprey study. So this Osprey study has some unique strengths. It's a randomized controlled trial as compared to the case series previously published. We had a higher BMI cutoff. The prior study had a BMI of 32. We went up to 35, although the FDA has now approved up to 40 kilograms per meter squared for the Inspire device. There's this technique called DISE, D-I-S-E, drug-induced sleep endoscopy, which is required for the Inspire device that's FDA approved. But we didn't do DISE, and we didn't need DISE. We had good response rates without putting people under propofol anesthetic. And that DISE procedure is really not very popular with patients or with ENT surgeons. It uses up OR time. It's not well reimbursed, and so getting rid of DISE may be one advantage here. We had some good racial and ethnic diversity, as I mentioned. Short procedure time. We had no inpatient visits, which is good. And we had a host of different patient-reported outcomes to show that we're not just making the numbers look better, but the patients feel better. So together with THN3, the JAMA ENT paper, the positive outcomes of Osprey established level 1 evidence for proximal hypoglossal nerve stimulation. We're now at the FDA with this technology. Okay, so let's talk about treating obstructive sleep apnea based on the underlying mechanism. There are lots of different mechanisms underlying sleep apnea, and so people don't all get sleep apnea for the same reason. So there's a woman, Jana Raffleson, who's in my lab, who wrote about endophenotypes. Endotypes are mechanisms of disease. Phenotypes are clinical expression of disease. And sleep apnea has many different endotypes or mechanisms. There's anatomical factors like craniofacial structure. There's the pharyngeal dilator muscles, the upper-airway muscles, which may be important in terms of mechanism during sleep. Arousal threshold, the propensity to wake up. A concept called loop gain, which is a control of breathing term that we don't need to get into today, but may be of interest. This issue of lung volume may be important. End expiratory lung volume can tether open the upper airway. And there may be vascular factors as well. The bottom line take-home message from the slide, those patients don't all get sleep apnea for the same reason. And this one-size-fits-all approach of giving everybody the same treatment regardless of their individual characteristics has largely failed. So mechanisms vary, but the phenotypes vary as well. The clinical expression of disease varies as well. So Li Xuan Yi is a PhD nurse who worked with us when I was back in Boston. Prior to that, she was in Philadelphia and published with the Iceland colleagues 3 different clusters of obstructive sleep apnea. There's a disturbed sleep group that had insomnia type thing, about a third of them with sleep apnea. There was a group who was minimally symptomatic or asymptomatic, about 25%. And there's a group with severe excessive daytime sleepiness that was about 43%. What's interesting is that group, the 43%, was later shown to be the group that's at cardiovascular risk. And so the reason that's interesting is that one-size-fits-all approach of just giving everybody CPAP and hoping it prevents heart disease is kind of doomed to failure if fewer than half of the patients are at cardiovascular risk from their disease. And remember I told you the randomized trials included a lot of minimally symptomatic or asymptomatic patients, and they're probably not the ones at cardiovascular risk either. It leads to this concept of differential susceptibility. When we talk about these upper airway muscles, though, there are some interventions that can be helpful there. So Brandon Noakes is a colleague in San Diego who works in my lab, and he's worked on this, what's called signifier or excite OSA. You put this mouthpiece in your mouth for 20 minutes a day while you're awake, and it electrically stimulates the tongue, improves the endurance of the tongue. So some prior physiology studies were done in my lab showed that sleep apnea patients have impaired endurance in their tongue, and looking at tongue endurance here, pre and post, you do see improvements in endurance with this electrical stimulation, so-called signifier or excite OSA. We did a little clinical trial here as well where the apnea-hypopnea index improved and the snoring improved and sleepiness improved as well. This was not a randomized controlled trial. This was an initial pilot study. Subsequently, Naresh Punjabi at Johns Hopkins, now in Miami, did publish a randomized study where he looked at adherence as the primary outcome, did see some benefits there. So stay tuned on this technology. It's now FDA approved, but more robust data are underway. Okay, so I'll do a couple slides of neuroscience here, which I understand may be not as much of interest to the audience, but I'll explain why I'm going through this. Nancy Chamberlain is a woman who I used to work with in Boston. She's now retired, but she can map these different reflexes and pathways in rats. So in the rat, you can do things that you can't do in humans, obviously. So in humans, we know if we suck on the airway, if you put suction pressure or negative pressure on the airway, the muscles of the upper airway will activate. It's the so-called negative pressure reflex. You suck on the airway, the muscles will activate to prevent collapse of the back of the throat. Well, same is true in the rat. You inject the tongue of the rat and label different synapses with pseudorabies virus vectors and see what lights up. So this is the brainstem of the rat. The hypoglossal motor nucleus is here. The dorsal motor nucleus of the vagus is here. The area postrema is over here. Nucleus of the solitary tract. This region here, called the periobex, ends up being quite interesting. With a pinpoint injection there, Nancy can modulate this upper airway reflexes and protect the reflex pathways in the rat. The reason it's interesting is this area, last Jack Kubin later showed, is heavily cholinergic. I mean, there's a lot of chat cholinesyl transferase. And so there's cholinergic targets here, cholinergic drugs that may be quite important, and those have been subjected now to clinical trials, as I'll show you. There are lots of different pathways here. So the hypoglossal motor nucleus is here, and this was published in The Lancet some years ago. The raphe neurons are serotonergic, and they project to the hypoglossal. The locus coeruleus ones are adrenergic, also project to the hypoglossal. Pediculopontine tegmental and lateral dorsal tegmental, these ones are cholinergic and project there. And then there's orexinergic ones from the hypothalamus as well. Why am I going through this for a clinical audience? Well, it turns out there are drug targets here that we can work on through adrenergic or through cholinergic pathways that may be worthwhile. So there's a drug combination being looked at called atomoxetine and oxybutynin. Atomoxetine is adrenergic, that's Strattera. Oxybutynin is anticholinergic, that is Ditropan. And if you're trying to improve upper airway dilator muscle function, you might use that drug combination. And it might be that low dilator function is important during sleep. The adrenergic stimulation could serve to activate those muscles. The anticholinergic may help to prevent suppression of those muscles during REM or dreaming sleep. So there have been some clinical studies done. The apnea-hypopnea index here on the y-axis, placebo and atomoxetine oxybutynin shown here. This one-night study did show a marked improvement in the apnea-hypopnea index with atomoxetine oxybutynin. You saw improvements in oxygen saturation as well, suggesting that this drug combination may be a useful thing to do for people with sleep apnea. In that context, they did see some changes in sleep stages. There were some increases in heart rate. Adrenergic stimulation, perhaps not surprisingly, can increase heart rate, increase blood pressure a little bit. And typically, we're treating sleep apnea to improve heart rate and blood pressure, but with adrenergic stimulation, they're going up a little bit. So this is a single night, overnight study, but it did lead to more robust studies down the road, as I'll show you. This is the so-called Mariposa study published in the American Journal of Respiratory and Critical Care Medicine by Paula Schweitzer. This is from 211 patients looking at what's called AD109. That's a drug combination of atomoxetine, oxybutynin. The oxybutynin, there's an enantiomer called R-oxybutynin. It's essentially the same thing, They did that, I think, for patent reasons more than anything. So that drug combination of AD109 is shown here, and you do see some improvements in the apnea hypopnea index with treatment. However, if you look carefully at the modified intention to treat analyses in this Mariposa study, the apnea hypopnea index improvement was about 5.9 events per hour, which is modest. It's certainly nothing to ignore, but not a home run. There are some increases in heart rate, as I mentioned, and some increases in diastolic blood pressure as well with this drug combination. So they've done 2 phase 3 studies now, which were reported this summer in 2025. The press releases, the papers are now in peer review, but they were presented at the American College of Chest Physicians in Chicago, so I'm allowed to talk about it. I was not involved in the study, by the way. APNIMED announces positive top-line results. AD109 met the primary endpoint. The apnea hypopnea index improved, and some reduction in the apnea hypopnea index. When you look at it carefully, what they presented, at least at the American College of Chest Physicians, this atomoxetine oxybutyn AD109 led to fairly consistent, though modest effects on sleep apnea. The AHI improved by between 3.3 and 4 events per hour. So that's not a big effect in terms of what they saw in the modified intention to treat analyses. There were a lot of dropouts of these studies. A third to half of them dropped out of their 2 phase 3 studies. Side effects will need to be considered in the context of hard outcomes. There were no improvement in symptoms here either in the randomized study, so it's now being reviewed at the FDA. I don't know what they're going to decide, but this was not a home run, at least in my estimation. Okay, so treatments to improve symptoms. If you have somebody that has sleep apnea, you treat their disease, right? You give them CPAP or you give them an oral appliance or something. But sometimes there's residual symptoms, and we do have drugs available for those now. So this was a consensus panel that was recently published. So Jorg Stier and I were co-chairs of this global consensus at Delphi conference, looking at clinical management of sleepiness in people with sleep apnea. It's hard to do a global consensus. It's like herding cats. Things like actigraphy, motion sensors are not universally available, so we couldn't recommend those. Multiple sleep latency tests where people do naps every 2 hours to quantify how quickly they fall asleep and look for objective evidence of daytime sleepiness, also not available in many countries, and so we didn't recommend that universally. There was general acknowledgement, though, that 10 to 20% of well-managed sleep apnea patients on CPAP still have residual sleepiness. So we emphasize treating the underlying disease, treat the sleep apnea, and if it's not adequately treated, treat it better. If you can improve adherence, do that. But if you've done all those things, then there was general acknowledgement that modafinil, Provigil, or solriamfetol Sunosi may be reasonable for some sleep apnea patients who are well treated with CPAP but have residual sleepiness. The reason I bring this up is that we've done a bunch of these studies with solriamfetol or Sunosi, and I ran some of those studies in full disclosure. But the solriamfetol Sunosi may have quite a role in patients with sleep apnea. It's now FDA approved and standard of care, at least in many patients with sleepiness. So this next portion I'm going to talk about is treatment to block sleep apnea complications. So what am I talking about there? Well, obviously when you're treating sleep apnea, you try to treat the disease. You prevent collapse of the back of the throat. You prevent desaturations. But there's other ways to approach this. So if patients having surges and catecholamines, at least in theory, you could give a beta blocker and prevent the effects of the catecholamines on end organ structures. So we've been looking at this a slightly different way, and that is based on the microbiome. So this paper was in New England Journal in 2013. The paper became controversial, but at least the concept is interesting. There's a molecule called TMAO, which is a choline metabolite, which is made by gut bacteria, and it can lead to atherosclerosis. And in this New England Journal paper, they showed with probiotics and antibiotics and whatnot, you can prevent atherosclerosis by suppressing TMAO, which is made by gut bacteria. This paper is now controversial, but we looked at this in a slightly different way. The idea was if somebody has hypoxia and hypercapnia because they're not breathing, could that affect the gut bacteria and affect the metabolites that the gut bacteria are releasing? Short answer is maybe. So these were data that we got with Gabby Haddad, who's a pediatrician here at UC San Diego. And look at intermittent hypoxia with hypercapnia shown here. These are data from rodents. during room air, and then they're given hypoxia with hypercapnia and intermittent hypoxia hypercapnia. We looked at atherosclerosis in terms of lesion size over here. So in the aorta, not much change in the aortic arch. You can see that intermittent hypoxia with hypercapnia did lead to atherosclerosis in the aortic arch. It did lead to atherosclerosis even in the pulmonary artery. And we gave a drug called DMB. What is DMB? DMB is a drug that blocks TMAO. And so by doing that, you can prevent atherosclerosis to some extent in the aortic arch and to some extent in the pulmonary artery. So the idea here would be you try to treat the apnea as best you can, but if you can't, the hypoxia and hypercapnia may have had effects on gut bacteria, which could then lead to release of metabolites that could promote atherosclerosis. So rather than treating the underlying disease, or in addition to treating the underlying disease, you might try and block the effects of those metabolites to prevent atherosclerosis. It's sort of a new concept, but it's something we're working on. Okay, so let's talk about weight loss. I think there's been a lot of excitement about this particular topic with the advent of these GLP-1 drugs, so let's talk more about that. This was a meta-analysis that we published just before the SURMOUNT-OSA result was released. The y-axis here is the percent change in the apnea-hypopnea index, and the x-axis here is the percent change in body mass index. These are lots of different studies. The blue dots are lifestyle, diet, and exercise studies. The black dots are bariatric studies. And then the green dots are the pharmacotherapy studies that were available at the time. And in that context, you can see as you lose weight, your sleep apnea improves. That's not a big surprise. We all know that. What's more interesting here is the shape of this curve. There's a lot of debate about it. Is it linear? Is it curvilinear? Is it quadratic? Is there a threshold so you get below a certain weight, your sleep apnea resolves? There's a fair amount of scatter here, too. Some people lose a lot of weight and still have minimal improvement in their sleep apnea. Others have other patterns. Some lose a little bit of weight and they get quite a marked improvement in their sleep apnea. The SURMOUNT-OSA result I'm about to show you had about 20% improvement in body weight and about a 55 or 60% improvement in sleep apnea severity, suggesting it falls in the red line and suggests that the improvement in sleep apnea that we observed may be largely attributable to body weight, although we'll talk more about that. So tirzepatide is also known as Mounjaro or Zepbound. It's a GLP-1 with GIP. What does that mean? The GLP-1 is glucagon-like peptide 1. GIP is gastric inhibitory peptide, also known as glucose-dependent insulinotropic polypeptide. It is different from semaglutide. Semaglutide is Ozempic or Rybelsus or Wegovy. That's a GLP-1 drug, but it's not GIP. And so in head-to-head comparisons, tirzepatide does a bit better in terms of weight loss, 20% versus 13% in the SURMOUNT-5 study in New England Journal. So it's not that one size doesn't fit all for GLP-1s either. So we published the study design here in Contemporary Clinical Trials. The design was the following. There were two different studies. There was Study 1 and Study 2. Study 1 were patients who were not using CPAP, and so they were just given tirzepatide or placebo to see what happened to their sleep apnea severity. Study 2 were patients who were using CPAP, who were given either tirzepatide or placebo. As a point of emphasis, there's no direct comparison here of tirzepatide to CPAP, so we can't say CPAP is better or worse or the same as tirzepatide. We could say tirzepatide is better or worse than placebo for Study 1 not on CPAP and for Study 2 on CPAP. It's tempting to draw conclusions about that, but we cannot do that based on the study design. All patients in these studies had monthly visits with registered dietitians, and I think that's an important part of standard of care. It's also, you'll see some improvements in the placebo as I show you the data. I don't think that's placebo effect. I think that's just from monthly visits with registered dietitians doing diet and exercise and whatnot. And in Study 2, the CPAP patients, we stopped the CPAP for 1 week prior to each sleep test to see if the drug was doing anything rather than just to say the CPAP was still working. So the inclusion criteria, we had age over 18 years. There were no children in this study. Moderate to severe sleep apnea, HI over 15, so nobody with mild apnea. BMI over 30, so nobody was lean or overweight. We excluded people with diabetes. That's important because people with diabetes tend to lose less weight with GLP-1 receptor agonists than do people without diabetes. So primary objective here is to demonstrate that tirzepatide, the maximum tolerated dose of 10 or 15 milligrams subcutaneously, once weekly, is superior to placebo for change in the apnea-hypopnea index from baseline to week 52. We had some secondary outcomes here, and I'd like to emphasize all of them were controlled for multiple comparisons, and all of them were pre-specified. So there's no data dredging here or funny business. What I'll show you here was controlled for multiple comparisons. We want to demonstrate that tirzepatide is superior to placebo from baseline to 1 year for the percent change in the apnea-hypopnea index, the change in the sleep apnea-specific hypoxic burden. That is a marker of the area under the hypoxia curve based on the magnitude and duration of desaturations. We looked at systolic blood pressure, which is obviously important, high sensitivity C-reactive protein, and we looked at the PROMIS scores, which are patient-reported outcomes. We wanted to make sure we weren't just making the numbers look better, but the patients feel better, and so we looked at the PROMIS scores there, which were developed by the National Institutes of Health. Study 1 were the non-CPAP patients, Study 2 were the CPAP patients. You can see the majority of patients in the tirzepatide arms completed the study, somewhat less so in the placebo patients. Presumably giving yourself a weekly injection isn't too much fun for a year. So there were some dropouts out of the placebo, but within the tirzepatide, it was quite good in Study 1 and even better in Study 2. Some dropouts from placebo in both studies. So this was published in New England Journal of Medicine in 2024, and on the basis of this study, the U.S. Food and Drug Administration approved tirzepatide as the first pharmacotherapy for obstructive sleep apnea. They approved it in moderate to severe sleep apnea in people with obesity. So let's look at the primary outcome here, the apnea-hypopnea index. Study 1, the non-CPAP patients. You can see a clinically and statistically significant improvement in the apnea-hypopnea index at 1 year. I'll show you two sets of results. There's an efficacy analysis, who stayed on drug, and then there's a modified intention to treat analysis based on randomization. The two sets of results are almost identical, but I'll show you both for transparency. So you see about a 25 to 30 event per hour improvement in the apnea-hypopnea index, which is quite good. Study 2, slightly more, if anything, 30 events per hour fewer with active treatment with tirzepatide compared to placebo. Again, you see some improvements with placebo, probably from monthly visits with registered dietitians and standard of care. So let's talk about these key secondary outcomes. These are cardiovascular related, some of them. There's lots of different outcomes here, but we'll just focus on a few. The apnea-hypopnea index change from baseline as a percentage improved by 55 to 60% in Study 1 and Study 2. If you look at high sensitivity C-reactive protein, a strong independent cardiovascular risk marker, it does improve with tirzepatide compared to placebo in Study 1 and with tirzepatide compared to placebo in Study 2. If you look at the patients you might consider in remission, so there's an apnea-hypopnea index below 5, where there's no reason to continue CPAP, or between 5 and 14 without sleepiness, Epworth sleepiness score less than 10, there's about 40 to 50% of patients on tirzepatide got into a category you might consider them in remission. I don't call that cured. The reason is if they stop the drug, the weight often comes back, or usually comes back, and so I don't think they're cured, but while they're on medication, they do fall into a category where their sleep apnea is well controlled in 40 to 50% of cases. Let's look at the hypoxic burden. This is the area under the hypoxic curve, markedly improved with tirzepatide compared to placebo. And if you look at the changes in body weight, there's about 18 to 20% with tirzepatide compared to placebo. To put that in context, if I weighed 200 pounds at baseline, a 20% improvement would be 40 pounds, or take you from 200 pounds to 160 pounds, so quite a game changer for these individuals. As I mentioned, we wanted to be careful. We weren't just making the numbers look better, but the patients feel better. Now, you have to be careful. When somebody's losing 20% of their body weight, you can't blind these studies very effectively. You can do placebo controls, but people know what's going on in terms of who's in which group. And so in isolation, these patient-reported outcomes become a bit meaningless. But with concomitant improvements in objective and subjective, I think it becomes much more compelling. So we recently published the symptom patient-reported outcomes improvement with this trial. And then more recently, just a few weeks ago, we published in Nature Medicine a mediation analysis looking at how much of the improvement with tirzepatide is related to sleep apnea versus how much is related to body weight versus how much is a direct effect of the drug. And it's interesting because it varies with the different outcomes. For blood pressure, it's almost all mediated by body weight rather than by sleep apnea, which is surprising to many sleep experts. But for other things like insulin resistance and lipids and things, so sleep apnea had more of an effect. But for blood pressure, it was more obesity. But they're both contributed in different ways, and so this was very recently published in Nature Medicine. Look at patient-reported outcomes here. As I mentioned, the PROMIS scores are developed by the U.S. National Institutes of Health. Sleep-related impairment is daytime symptoms. Sleep disturbance score is nighttime symptoms. And in this modified intentional treatment analysis, you can see a marked improvement in the PROMIS scales, both in terms of daytime symptoms over here and nighttime symptoms over here, suggesting patients felt better. Let's talk about safety. About 75 to 80% of patients across the board, both in the treatment arm and the placebo arm, had some treatment-emergent adverse events. It's not surprising. If you follow carefully patients who are unfit, they tend to have these kinds of complications, whether they're getting drug or placebo. In terms of serious adverse events, there were numerically more with tirzepatide than placebo in Study 1, although small numbers. And in Study 2, there were numerically more with placebo than with tirzepatide, but again, small numbers. There were 0 deaths, which was good news. Treatment-emergent adverse events of there's some like GI side effects, so nausea, vomiting, diarrhea, constipation. Quite common in Study 1 and in Study 2. About 25% of patients will develop nausea, vomiting, diarrhea, constipation. The good news is twofold. Number one is, as I showed you, very few people dropped out of the study because of side effects. They continued through it. And by 1 year, these side effects are largely resolved. And so these side effects tend to be manageable. But certainly patients need to be warned that this could be a possibility if they start on medication. Okay. Adverse events of special interest. So we were worried about pancreatic cancer. We saw 0. We were worried about medullary thyroid cancer. We saw 0. We were worried about death. We saw 0. We were worried about pancreatitis. We did see 2 cases with tirzepatide and 0 with placebo. And I do critical care as well, so I know a modest amount about pancreatitis. And so I did a deep dive on these 2 cases to figure out what was going on, because I was worried about them. And they're both quite mild. In fact, I couldn't figure out why they're diagnosed. And I think what happens is what's called an ascertainment bias, where patients come in with nausea, vomiting, abdominal pain, and people check an amylase and lipase because that's what you do when somebody has abdominal pain. So I think some of these were picked up perhaps through an ascertainment bias rather than a real toxicity. But these are not to be ignored, certainly. There were 2 with tirzepatide, 0 with placebo, but both quite mild. There's some dynamic changes that happen over time, so we published on this as well quite recently. Here's we did these watchpat devices where we looked over time how things were changing. So the x-axis here is time. Here's the change in the apnea-hypopnea index on this y-axis, change in body weight on this y-axis. You can see within 4 weeks in this trial you start to see separation from placebo. So tirzepatide is leading to some improvement in body weight and some improvement in sleep apnea severity. By 12 weeks, there's more clear separation, and by 20 weeks, there's statistical significance. So this is something I tell my patients, that we need to treat your sleep apnea and your body weight. If you start on tirzepatide, your sleep apnea will improve within 4 weeks, but clear-cut improvement takes a few months. And by 1 year, you can see there's about a 20% improvement in the body weight, as we showed you in the summary statistics. So this was published, the time course, in the Journal of Sleep Medicine a few months ago. In the SURMOUNT OSA Study 1, that is the non-PAP patients, measurement of this watchpat AHI with a wearable demonstrate clinically meaningful improvements in sleep disorder breathing with tirzepatide treatment in adults with moderate to severe sleep apnea and obesity. Significant improvements versus baseline were observed as early as week 4. Improvements were statistically significant compared to placebo by week 20 and week 52. Reductions were accompanied by changes in body weight. So people ask me, what do you track if you start people on these medicines? You can track their body weight, and that tends to parallel the improvement in sleep apnea. So what are the key takeaways from SURMOUNT OSA so far? Tirzepatide at the maximum tolerated dose demonstrates superior and clinically meaningful improvement of obstructive sleep apnea-related sleep disorder breathing. Tirzepatide at the maximum tolerated dose demonstrates superior improvement of patient-reported quality of sleep and sleep-related functioning. Treatment with tirzepatide, the maximum tolerated dose, translated to clinically meaningful improvements in obstructive sleep apnea and obesity-related cardiovascular risk factors. The safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with the safety profile of tirzepatide and incretin-based therapies in people with obesity. And this mediation analysis, as I was in press, was just published now in Nature Medicine, as I showed you. I often get the question, what's the future here? The short answer is I don't know. There's a molecule called orforglipron, which is an oral GLP-1 receptor agonist. I'm the global PI for a study called ATTAIN-OSA, which we should have a result on in this calendar year in 2026. The TRIUMPH studies are looking at a drug called retatrutide. Retatrutide is a GLP-1 with GIP with a glucagon agonist, and that's showing very good weight loss, more than tirzepatide even in some of the preliminary findings. And so that, I don't have the result of that yet, but that manuscript will be written hopefully soon. BELIEVE is a study that looked at a drug called bimagrumab. Bimagrumab is a skeletal muscle agent that helps to prevent loss of skeletal muscle or sarcopenia, and that may be an interesting molecule to keep an eye on. One's called eloralintide, was just published in the Lancet a few weeks ago, and that's an amylin-based drug that also promotes weight loss and may have some better side effect profile than tirzepatide, at least for some patients. Perhaps combinations of therapies may be worthwhile. FDA approval pending for many of these things. There's also some siRNAs that are now being looked at to prevent skeletal muscle breakdown. So single injection may be helpful in terms of preventing skeletal muscle breakdown. So I'll conclude the talk by saying the following. It's an exciting time for the sleep apnea field. 10 years ago, we basically had CPAP and not much else. Now we have a range of different therapies. Pharmacotherapy is not just coming, but it's here. There are a number of new FDA-approved therapies that are available for our patients today. Individualizing therapy may be viable based on their underlying mechanism and based on their symptoms, and it's an exciting time for ongoing research. So I'd like to thank you all for your attention. It's been my honor to be here today. Thank you.
Thank you so much, Dr. Malhotra. This was an excellent overview of the management, and we'll now turn into the Q&A section of the presentation. Thank you.
Well, thank you for your attention. Thank you for the questions. I did prepare some frequently asked questions in case these come up. So I often get the question, are these drugs long-term? The short answer is yes. The SURMOUNT-4 study was a randomized withdrawal study where they took patients with excess body weight and gave them tirzepatide and brought the weight down. Then randomized them to get either ongoing tirzepatide or placebo. So it was a randomized withdrawal. And when you do that, you have tirzepatide here. The body weight comes down nicely. If they continue tirzepatide, it continues to improve. If they go to placebo, it goes back up. Not quite to baseline, but if you follow them out to a year, the majority of them are back to baseline. And so weight regain is a real issue here. Potentially, at least you can maintain weight loss via diet and exercise, perhaps. I see some patients clinically who have done that. They lose a bunch of weight and then don't need the meds anymore once they get highly motivated to go to the gym and whatnot. There are newer agents in development as well for skeletal muscle, like bimagrumab, as I mentioned. There are oral maintenance approaches as well. The good news is if there is long-term follow-up in terms of medication use, things look quite good. So the SURMOUNT-1 study was published in New England Journal some years ago. The 3-year follow-up to that was just published in New England Journal last year. And if you stay on tirzepatide, your incidence, new onset diabetes at 3 years goes down 93%. And so it's really quite a long-term benefit in terms of treatment. So are these long-term drugs? The answer is yes. Should pulmonary providers be prescribing GLP-1 receptor agonists, or is this something that should be left to endocrinology or bariatric medicine specialists or primary care for that matter? So the answer is yes, probably, but there are some logistic issues. Insurance approvals and prior authorizations and appeals. My wife is an endocrinologist. She says about 80% of the calls they get are related to logistics of getting GLP-1 receptor agonists. The pharmacists were running out. That's less of a problem now, but at least that's an issue. The trials are done with monthly visits with registered dietitians. Many pulmonary clinics or sleep clinics don't have that luxury, and so I think resourcing adequate dietary education is worthwhile. A lot of these clinics have backlogs, and so there's access issues with sleep clinics as well, or pulmonary clinics. And you need to be able to handle or assess complications. So I have some sleep medicine provider colleagues who are trained in psychiatry, and they're not comfortable working on pancreatitis or abdominal pain or those sort of things. And so you need to be in a practice where you can manage not just the patients and their medications, but potentially their complications. Okay. Are these drugs expensive? The short answer is yes. There have been some price lowerings recently, if you're following the political news. On Lilly Direct, which is their website, you can get tirzepatide for about $500 a month. which is a lot of money, but it's not prohibitive. Insurance coverage is pretty good, even for undercompensated care. So in San Diego, we have Medicaid, Medi-Cal, Molina, some of the undercompensated care patients, and many of those are covered for GLP-1 receptors now, although some of that changed on January 1st. There's reduced cost of complications, including things like diabetes and dialysis. I had dinner with a gentleman a few months ago whose wife is a vascular surgeon, and she canceled 1 OR day per week because she's putting so many fewer AV fistulas. Dialysis rates are way down. I've had patients tell me they save $20 a day on food, one meal less per day or less groceries. So $20 a day, if you do the math, is $600 a month. That will actually pay for the $500 a month on Lilly Direct. And so I've had patients say it's cheaper for me to take the med than not take it because of the food. Alcohol and tobacco intake also go down. Gambling goes down. So there may be some complex questions here. Are these drugs expensive? The short answer is yes. But there's some savings that come with these drugs that may be worthwhile, at least for some patients. Do you lose skeletal muscle with GLP-1 or the short answer is yes. So if you lose 20% of your body weight, some of that's going to be muscle, some of that's going to be fat. The amount of each is debated. Most recent data suggest about 20% of the weight loss is skeletal muscle, but these estimates vary. You can mitigate some of that muscle loss by resistance exercise, potentially with oral protein intake as well. The skeletal muscle agents are in development by many major companies. I mentioned bimagrumab, the so-called BELIEVE study, where it was quite impressive. It's an activin inhibitor, so it prevents the breakdown of actin and myosin, and that seemed to preserve skeletal muscle, and so people are able to lose fat but not muscle using that agent. As I mentioned, there's siRNAs as well. There's one called WVE-007, which is in development that looks interesting. Some amount of loss of muscle and bone density is appropriate as class 3 obesity resolves. So if you weigh 400 pounds, just to stand up, you need enough axial strength to be able to bear that much weight. And so as you lose weight, then some of the demand on those muscles and bone gets less. And so there's some appropriate changes that happen as you change your body habits. Another question I get is the mechanism of improvement in surmountable OSA, is it all weight loss? And I mentioned from this graph, 20% improvement in body weight leads to about a 60% improvement in the apnea-hypopnea index, and so that suggests it's mediated by weight loss. But the degree of improvement in the apnea-hypopnea index is largely predictable from the change in body mass index. However, the marked improvement in systolic blood pressure and other variables, to me, suggests some off-target effects. There's Julian Payton has a paper in Circulation Research looking at sympathoexcitation via the carotid body induced by hyperglycemia. You can block that with GLP-1 receptor agonists, and so potentially at least there's some autonomic effects of these drugs that may help with improving blood pressure. Something called hedonic eating as well. Hedonic eating is eating for pleasure rather than for hunger. Some of these addictive behaviors like alcohol, tobacco, gambling go down, and so some of these may be off-target effects of the medications rather than simply weight loss. Okay, I'll stop there. I thank you all for the questions.